Well, hello and welcome to today's event, a virtual roundtable looking at the impact of the publication of the Trusted Exchange Framework and Common Agreement, better known as TEFCA. The publication of TEFCA marks the beginning of a new era of electronic health information exchange in the US. Our industry leaders are here today to unpack TEFCA and what it means for health information exchange and your organization, including implementation timelines, use of EHRs, and other critical components. And welcome panelists, welcome Jim. I'm going to turn it over to you now and go on mute. So I'm looking forward to the conversation and we'll see you back at the end.
Well, Carol, thanks so much for that introduction. We've certainly got the players on today who can educate me a little bit, hopefully. I'm a closet historian, so I always like to know where things come from. And this whole concept of TEFCA, or the Trusted Exchange Framework and Common Agreement, was born in 2016. President Obama signed the 21st Century Cures Act, which called on ONC to develop or support a trusted exchange framework, including a common agreement among health information networks nationally. So over the next hour, we're going to unpack that. I've got a lot of questions. I think we've got the right people on board to give us some of those answers. The Trusted Exchange Framework Common Agreement version 1 was published January 18th, 2022, so just about a month ago. This is a timely topic. We're at the beginning of this whole process, a lot of planning behind it, but it's, as they say, the eagle has landed. And today we're going to find out a little bit more about it. The first question I have for our panel, I'd like everybody to weigh in this, is why is TEFCA needed? What is not in place now that we need? Another type of agreement or set of standards? Paul, I'll ask you first, and then we'll do a round robin. Why is TEFCA needed?
Yeah, it's a great question, especially when you go back as a historian back to 2016. I think when it originally was proposed, we were nowhere near where we are today in terms of interoperability in the United States. So there are some that kind of look at this thing and go, aren't we sending up a rocket to push a rocket that's already achieved escape velocity? What's the point here? And I think, first of all, there's more work to do, and there's some leapfrogs that we can make here. If for those of you who search on some of the comments we made in the early comment periods before this edition that came out a couple of weeks ago, we commented on some of the forward-looking things, saying, maybe don't go that far because we have things to launch, and there's things like the FHIR roadmap. I think now that things like the FHIR roadmap are out there, great, jump on board, go crazy. Let's accelerate that rocket because it's still sitting on the launch pad. And quite frankly, for the way CommonWell operates, this actually kind of levels the playing field in a good way for us, in that the way we do exchange, which is more record locator based and finding a person versus finding sites that have patient records, which is a nuance we can talk about later, kind of endorses that across the whole country. So it brings us kind of along to our philosophical thing and kind of makes a hybrid of a bunch of other networks that are working right now. Our job right now with Mariann, with Sequoia and everybody else is to make sure that hybrid is the best of all our pieces, not the worst. And that's our task for the next 2 years.
Lee, what about you? Why is TEFCA needed now?
I think that Paul talked about some really good things. There's a lot that's happened, a lot of great things that have occurred since 2016. We look at ONC started this FHIR at Scale Task Force initiative with about 7 different hierarchies looking at FHIR, again, in an effort to try to move that forward as application program interface for interoperability. A lot of work has gone on there. I go back to really a very simple example. Today, I use the example that if I was traveling and I was rolled into an emergency room in California, that attending physician has limited information on my EHR. And so they'll do everything they possibly can to try to make me comfortable and do what they can. But without my entire EHR, they are limited as far as what types of treatments that they can provide. If we fast forward this, where we move forward with this interoperability network and TEFCA, over the next 2 years. Take that same example, and I believe that where we'll be is if I get rolled into that emergency room unconscious, they'd be able to get my wallet, be able to key in from my license or any other identification into the EHR system, and they'd be able to pull out all these qualified health information networks, put together and assemble my EHR in seconds, Jim, and then all of a sudden, that attending physician has got all of my information in the entire treatment process that's going to take place is going to be much better. And so mortality goes down and overall treatment is going to be much better. So that's how I look at this in relation to why interoperability and why TEFCA is so important for the industry.
Mariann, how do you see this? What is TEFCA bringing to the table that's not already on the table?
Well, and it's a great question because before TEFCA, there is a private sector driven initiative called Care Equality that has a similar approach in supporting a trusted agreement to interconnect networks. And that's been phenomenally successful in enabling healthcare organizations to connect to each other, regardless of the network they participate in, and share information to treat individuals. And that is, again, phenomenally successful. I think we'll reach 4 billion records exchanges this year cumulatively. But what we haven't been able to really move the needle on is bringing other actors into this nationwide ecosystem, specifically health plans, to be able to access and share information for payment and healthcare operational purposes. We don't really see individuals have ready access to their information in all the places they receive care, or they have to, access their information through multiple portals. And is there an entry point for the individual to be able to access their own information nationwide in all the places they receive care and where their information is held? Public health, I think we've seen with COVID that, information was not readily accessible, and public health agencies made a multitude of requests, and so there were healthcare organizations and networks that were receiving a multitude of requests from different public health agencies, state, local, and otherwise, that were just fairly duplicative. And so there is an opportunity to build upon the backbone that we have and have a government endorsed approach to designate these networks, these super nodes, to support these multitude of purposes for a public good purpose.
Damon, I'll throw it to you. Is TEFCA needed now? Why is it needed?
Yeah, absolutely. And I think Lee described it really well, just from the perspective of the person, the individual, the consumer of care. And we're at I feel like we're finally approaching a tipping point where our technology, the frameworks that enable information exchange, the economic models, and the regulatory frameworks for the industry are really going to allow us to begin to achieve the personalization of care experiences at scale. And you really have to do that individual by individual by individual. So as much as anything, I'm thrilled, excited about TEFCA. I'm learning, like much of our audience, exactly what it's going to mean and in what time frame, so that we at Dedalus, which by the way sounds like setting your data loose, which I think is apropos for the conversation, is the reason that we exist, and to help industry participants, both legacy and new, non-traditional industry participants, really collaborate to impact health and well-being at scale, person by person by person. So the framework for nationwide clinical data exchange that TEFCA represents in my learning brain right now is just a tremendous advancement. So I think we should celebrate it. So congratulations, by the way, to the organizations that have been so instrumental in making it real. I think it's going to be very interesting to see the pace of new change associated with TEFCA. We're starting with CCDA exchange, then FHIR, then what's next. And of course, the next question is, what about everything else you need to know about me to actually personalize the care experience that I have? Because as we know, only some limited amount of that exists in the electronic medical record, but huge step forward, I think.
When I first heard about TEFCA, my initial questions are, what is this? Is this technology? Is this incorporate new data standards? Is it regulations? Just what the heck is it? But one thing I found out pretty quickly is that at the leadership role is something called a recognized coordinating entity. And so we've got Mariann on board, and Sequoia, the Sequoia project is that recognized coordinating entity, also known as RCE. So Mariann, tell us a little bit about what the RCE does and what the plan is.
Sure. So ONC, as you know, was directed to establish TEFCA, and we're given the ability to work with a private sector organization to help implement it. So think of the role of the recognized coordinating entity is we're the government designated body, we're a private sector nonprofit public good organization, and that we work with ONC to develop the common agreement, to develop and maintain the common agreement, the QTF, the QHIN technical framework, and to provide oversight and governing approaches for the networks that want to receive this special government designated endorsed status as a TEFCA qualified health information network. So we are working with ONC, getting input from stakeholders to develop, think of the legal agreement that QHIN signed to exchange information with each other, and that we are also a party to that agreement. They agree as a byproduct of signing that to comply with the technical requirements in the QHIN technical framework, or QTF. But TEFCA is really focused on QHIN to QHIN exchange, recognizing that each qualified health information network represents a connected set of organizations or individuals. And so we're really providing that coordinating role, working and maintaining the common agreement, the QTF, and then we are the body that will actually facilitate the onboarding and designation of QHINs and facilitate oversight and monitoring of them going forward. So it's very integral through development of the framework and maintenance of it itself, as well as overseeing exchange of information.
Well, I understand what the role of the recognized coordinating entity, but these QHINs, and I think they were referred to a little while ago as a super network. Are these like what used to be called the RIOs, or now the health information exchanges, or the hospital systems? What are these QHINs? What's an example?
So we don't have any QHINs designated yet. But the expectation is that we don't want to just duplicate the network topography that we have today. A QHIN is really a special set of characteristics and attributes, and they really represent aggregation points, not necessarily aggregation of data, but aggregation of connectivity. So a QHIN could connect HIEs, health systems, health plans. It could, connect individual access service providers, such as apps that individuals use to access their information. They are really a network that has the technical abilities and the attributes to connect information and connect to other networks on a nationwide scale. The expectation is these are high volume, highly reliable networks. They're high security, they're strong financially, sustainably, organizationally, and they can demonstrate existing competencies supporting this volume and level of exchange, which we expect will be in the tens of millions of transactions a day. So it's, again, there is a role for all in the ecosystem today to participate in TEFCA. We believe a subset of networks will really have the competencies to really serve as a qualified health information network. So
these QHINs, and I don't know if Lee or Paul or Damon want to weigh in. How are they going to be funded? That was one of the troubles with the regional health information organizations, is that there was no financial underpinning for many of them. So what's the benefit, or who's going to pay for that for these QHINs? Is that even known yet?
Well, I mean, first of all, CommonWell is a QHIN candidate and very, very unlikely not to be applying in the first round of applications to come out in the second quarter of this year. So, the funding model, I think what Mariann's hinting at, and is a little bit of a whack to some that are small and trying to figure what to do. This is not for the weak and weary. When she says tens of million transactions a day, I mean, we're concerned about tens of million transactions an hour, right? Quite frankly, because there's pockets of time between, say, 7 o'clock Eastern to 5 o'clock in the afternoon when the stuff is concentrated, and sometimes it bubbles up to massive numbers. So yeah, you better be well funded, well organized, well designed from a technical perspective. Kind of need to already exist and already have your sustainability model in place. This is not our money. This is not going back to stimulus money back 10, 20 years ago, where it was let's start some new things. There are things we need to reshuffle the deck a little bit to make it work a little bit better, right? So you can imagine it's great that we have care quality and we have a way to interact with each other. But there's a little bit of a kick to some that are saying, what should I be doing? I don't understand how this links with other programs at a federal level. This private industry thing is great, but what bet should I be making? And I think this is going to make some people make some bets faster. What we don't want them doing, and I don't want to speak for Mariann, but I'll speak for the entire industry on this one. And there's a warning to everybody. The bet is not to be a QHIN. The bet is to figure out the QHIN should be part of. And if you can't have one that fits, think about starting to develop one, understanding it's probably going to take you 2 years to get there. You don't start out blank slate with an investment fund and a couple servers in AWS and say, I'm going to be a QHIN today. Kind of need to have a history of how to do this almost at TEFCA scale without their TEFCA existing. We're effectively connecting AT&T and Verizon to make phone calls go across each other, and also make sure that Sprint and T-Mobile and all them work too at the same time and create innovation. But the first set really, for this to work right, the first set had to come out of the gate pretty much knowing what to do and how to interoperate with each other so we can plug in more and make it seamless for a national framework that is less disjointed than we have today.
I'll throw a question out for anybody who chooses to rise to the occasion. What is the common agreement? What's that all about? That seems kind of important.
It is. So the common agreement is the single agreement that all QHINs would be expected to sign and comply with, and the RCE would be a counter signatory to that. I say it's a single agreement because there's not a one-off revision with any particular party. And this agreement was developed with strong guidance and policy parameters defined by the ONC, which was also informed by other parties within the HHS, Health and Human Services, such as the Office for Civil Rights. And so these are the terms and conditions that QHINs have to abide by, puts forward expectations for the purposes for which they may exchange information via TEFCA. It establishes when they must respond to requests, for instance. It puts forward expectations for privacy and security and liability and et cetera. So it's really the rules of the road that are contractually binding by those who wish to serve in that role. There also is this really, really important concept that QHINs have to flow down certain expectations to the organizations that connect to their network, which we call participants, as well as those who might be connected therein. So if a health information exchange, for instance, connects to a QHIN, then they also have to flow down expectations to those that connect to that HIE. Okay. And so really think of it as the underpinning of the contractual requirements.
The whole issue of the common agreement, so that's not been published yet. I guess it's in some draft format, but the technical framework, the QHIN technical framework, is that going to be the technical standards and requirements related to the actual data?
So the common agreement actually was published on January 18th, along with the QHIN technical framework. I would think of the QHIN technical framework as the implementation guide that puts forward the technical requirements, the underlying standards, the technical and functional expectations that QHINs have to support. And so that would be more to the technical counterpart to the legal and policy parameters in the agreement.
Lee, I've got a question for you. From my understanding, TEFCA is a voluntary process. How is that going to go? Are we hoping that if we build it, they will come?
I think, well, Jim, I think there's a couple things I'm going to say. So first, in answer to your question, I think even though the fact it's voluntary, I think there's already a pretty good pipeline of organizations. And one question I saw coming up on the chat, is this going to be for like the epics only? And the answer is no. I think there's going to be, we're going to see a lot of healthcare information networks, HINs, care quality and others, HIEs that are have fairly large infrastructures and state and regional that are going to move forward to make application to become a QHIN. The fact that it's voluntary, I think initially, I really believe that can work really well. If in fact we start to see some of these QHINs operationalized and the entire process as we're looking at from a timeline, by the end of the year, we start to see these QHINs start to operationalize. We start to see some of the use cases actually proving out to be successful. I think we're going to see a lot more entities that are going to want to not only become QHINs, but also want to participate with the QHINs. Mariann was talking about the fact that there are participants and then there are sub-participants, health plans, provider organizations, hospital systems, labs, pharmacies. All of those will play a role in relation to providing input and data into these QHINs. So, I think that these success models, we're going to see these success models starting to occur. And Jim, it's just like anything. Once you start to see, organizations start to see successes, others want to not be competitively disadvantaged by not participating. So I think we're then going to see, a fairly large influx of organizations that are going to want to participate and be part of this. But it's really going to come down to the use cases. And I think by doing it voluntarily, it is fine. And I think that I really believe that ONC was of the belief, if we do it and we can create the use cases and people can see the benefit and the value proposition to them, as well as the other key part of this is really about patients and patients having a lot more access to their data, including their caregivers. For example, I take the situation that somebody's going through cancer treatment. Today, many of those patients are so ill going through the chemo, et cetera, they can't manage all of the various entities and individuals that are part of that whole treatment process for them. So being able to have the ability for even their caregivers now to have access to this information and be able to coordinate on behalf of the patient really starts to give the patient's caregivers a lot more control and a lot more access to the data. And really, I believe that that's a very fundamental benefit and goal of TEFCA.
Lee, you gave a comment there. I want to ask Mariann about. Lee said he thought, or at least intimated, that by the end of this year, there'll be some QHINs in place and maybe some data moving. Is that a potential? Will we see things happening in 2022? Will data start moving?
Well, potentially.
Yeah.
So we plan to open up the application process for QHINs in Q2 of this year. Really depends on how quickly it takes these organizations to go through the process, first of which will determine whether or not they're eligible and meet the criteria. And then, whether they have provided and demonstrated that they can meet all the expectations and the criteria. We actually, just to clarify, Care Equality is actually part of the RCE team, because Care Equality is the private sector's version of TEFCA. TEFCA. Carry
Okay.
Quality supports a framework that currently connects networks today, again, principally around treatment. And so that group will actually operationalize and support the onboarding and designation process. And so we're gearing up for that. It's quite possible, likely we hope, that there will have the initial group of QHINs through the onboarding and designation process this year, which also includes they'll have to complete technical testing, non-production partner testing, and then production partner testing. And so again, those networks that are established and have these proven competencies are really, who we would expect to come through. And there are a number of them that exist today. So quite possibly, yes.
Damon, I have a question for you. Anytime we talk about interoperability, there's one thing that always bothers me, and that's the fact that we do not have a discrete, unique patient identifier in the United States. We can't use social security numbers. So if we're moving all this data, and I'm from North Carolina, but I happen to be in California and go to the emergency room, how are they going to be sure the data that they receive through these networks is my data?
Right. Good question. And it'll be interesting to see us solve this one at national scale. I mentioned earlier that I really do think we're at a tipping point in terms of technology maturity and sophistication to do. And one of the things we can actually do quite well now is identify people from a number of different characteristics and narrow that down to the individual. Think about what we've been able to do in the financial services industry by really making sure, and that's as important in identity and security equation as we're talking about in healthcare, right? But we figured it out. And in fact, one of the things I think is really interesting and encouraging, and I would just remind everybody to don't underestimate the power of the consumer to drive adoption. I wanted to jump in on that earlier question, Jim, but I didn't want to be rude. I mean, If you think about a voluntary program like this, it's classic change management, right? You make it voluntary at first and people do it, and then it becomes the rule. And I imagine that is exactly how this will play out here on a nationwide scale. But think about financial services, what we did there to make sure that identity and security are things that consumers can rely on. And we really transformed the industry from banking to financial services. When I started banking in the 80s, that's literally what we were doing. We didn't even call it financial services at the time. We had interesting different types of banks. But it's when we managed to secure the information and ensure identity, we created real financial services. And I suspect that we're going to experience much the same sort of revolution in the healthcare industry, in a transformation from healthcare to health services around this idea of nationwide identity and security of my information and portability. We keep forgetting, or we often forget, that the P in HIPAA is portability, not trying to keep something out of the consumer's hands or the physician's hands.
One thing I'm really curious about, and like to hear anybody's opinion who wants to give it, is how this is going to affect EHR vendors and the EHR software. Most software systems now, EHRs, can download somebody's medication history from SureScripts. That's been available for some time. What will vendors have to do to enable the ability for providers to access this information?
I think there's multiple components to that, but the first thing to think about is there are already vendors who do this today at a pretty big scale. So when I said that, that rocket ship doesn't need another rocket ship to hit it to go any faster at this point, the reality is we have probably 60% of the provider entities covered and connected already. And this is a ballpark, right? So there could be 80, it could be 55, but it's somewhere around 2/3. We'll use that. The reality is, and I've been through this exercise having worked at an HIE, a regional HIE, it's sometimes unclear what that 1/3, what you're missing and how important that might be. So the accelerant to finish the job is important. I was with HIEs that would always talk about healthcare is local. 97% of the data that everyone to see is going to be within, say, 20 miles of where I am or 100 miles, wherever it is. I have no need to connect to this other thing. And my response would always be very similar to some of the comments that are made, and some of the things going on in the chat are, but what about that exception when I'm not where I'm supposed to be? So I live in New Jersey. I'm in Ohio for whatever reason. I'm seeing the Ohio State Michigan game. I'm not a fan of either team. Just say I'm there, and something happens. No one in that community has a darn clue of anything healthcare wise about it. There's no one to call. There's no primary care provider they know that can say, here's something you want to know about heart conditions or any past. We need it all connected, right? Otherwise, that 3% when it happens is more and more of a disaster. And we always talk about 80-20 rules, right? 80% of your healthcare costs and the last 20% of your life. I'm going to wager that that 3% problem in ED is probably a significant cost problem and not just a clinical quality problem as well. So let's fix the third left, and let's fix that 3% so that we can rely on the networks and we don't have to keep interrogating about what data is missing. Like, I am not the best custodian of my data. I know some things. I'm actually probably, like everybody else on this call, probably on the geek side of this, and probably do track everything and make sure everything's pristine, but that's not normal. We are, normal people don't come out of high school and college as clinical experts. They don't know what's relevant. They don't know what to remember. Therefore, it gets locked away and isn't brought up at the time it should be. Getting all the data available at the point of care to the person at the right level to use it is really important, and getting the rest of it done. So I think that's what we're getting towards. And I do think it's right that, getting patients engaged is likely to fix some of that. That's one of the big leaps in TEFCA. And quite frankly, it's one of the leaps that some of the vendors and providers are a little concerned about, is that right now we're doing great, excuse me, great provider-to-provider exchange, but adding in provider to patient, what I always call the crossing of the Ps, provider to patient, provider to payer, payer to patient. Anytime you change those Ps, they're all Ps in public health too, put that in there as well. It gets harder because the trust establishment is different. And I think TEFCA has the opportunity to kind of say, one, yes, we should finish this job and fix the rest of the network. And two, it's kind of a compelling kick in the rear to get the patient engagement going and get them the access today they should have already today.
And just building on that, I think as Paul had mentioned, most electronic health record systems already support the standards being put forward for TEFCA, but they really, it's TEFCA's focusing on the standards and specifications and requirements to connect QHIN to QHIN. So electronic health record vendor is likely an enabler for the providers that use that system to connect. And they should be able, some QHINs may translate from different standards to what's required for QHINs, et cetera. So the idea is, again, layering on top what exists today. But there was a question or a comment earlier that, the Common Agreement contemplates 6 exchange purposes: treatment, healthcare operations, payment, individual access services, public health, and government benefits determination. We heard very, very clearly that there is more specificity and granular requirements needed to be specified around purposes related to payment, healthcare operations, because they're so vast. I mean, they cover a massive set of possibilities. And that's an area that's been really tough to unpack. And similarly with public health, well, which aspect of public health, and which, we talk about public health reporting, electronic case reporting, what, and even government benefits determination. So there was a policy decision, and it was really supported fairly universally. Well, let's start the initial rollout with treatment and individual access, and then take time, form a work group, and really spell out, well, which payment purposes are we talking about? Is it quality measures? Is it risk adjustment? What aspect of healthcare operations? Because to really have unmediated exchange that's all automated, that we felt that organizations need to have greater assurance about what specifically that means.
Yeah, and just to add one bit, and Jim, you probably have other questions asked, but I think the part of the reason why we need to add something, right? Otherwise, what's the rocket fuel we're adding? Just doing more provider-provider exchange probably isn't enough. Adding fire to the roadmap feels like it's a jump. And quite frankly, that will get some of the vendors that don't have the XA capability. It is true that the TEFCA, the TEF and the qualifications go along with it are about QHIN to QHIN exchange, but a lot of the flow down does look the same on the inside. I mean, CommonWell happens to have a fire to XCA converter to help people, right? But there are a fair amount of EHR vendors out there that are newer, don't have some of the legacy stuff that is currently specified as the first release of TEFCA, that are probably looking for TEFCA 2 years from now, which we got to get to. And I think that's really important. But these two use cases are unique in that if you take those 6, all those entities are entitled to all the data. That's something that's the same about them. A provider can see some consents in place, but once you reveal the blob is the whole record. It's not an atomic set of things that you might request. For example, public health, many states, the public health department is only supposed to get a certain set of elements. And if we gave them what we give them today, which is everything, because that's the filter, it's once you know it's Paul Wilder, here's all the Paul Wilder stuff. The trust of that they'll be careful with it and only extract what they want from it. I think we trust them on that. They don't often trust themselves because their systems aren't designed to take that kind of data. They're really designed for 9 elements or 11. So, getting to adding those use cases may require, for example, jumping to fire faster so we can do more atomic level. I just want this resource because these are the things, and it might increase trust because I can say, I'm only going to get what I'm authorized to get and stop the conversation a little bit about, let's talk about what you're authorized to get. Why don't you just tell me by what you ask for? But right now they'd have to ask for everything, highlight and snip and take apart, which is a little bit uncomfortable to everybody. So I think this is a start to adding a bunch of use cases that we all would have loved to have done for the last decade, but have been hard to do because adding trust, crossing those P's is harder than it sounds. And we need a little more work before we launch that in earnest.
The concept of public health was just mentioned probably 4 or 5 times in the last 2 minutes. And the COVID-19 pandemic really exposed gigantic gaps in our public health data. We didn't get it in real time. It wasn't standardized. If depending on what state you were in, if you got tested 3 times and were positive during one COVID experience, some states would report that as 3 positive tests, even though it was really just 1 case, 1 individual. So a lot of gaps were identified as this data was rendered up. What's TEFCA going to do in terms of public health and data so that those policy decisions can be made in more real time and more accurately? Is it going to affect that type of data?
So
I'll leave it. Yeah.
I'm happy to jump in. I mean, first of all, I think that we have a roadmap to add more use cases, and that's fantastic. I think some of the questions here are hinting at one of the problems in public health, and that is not necessarily as apparent on the provider side anymore. A lot of questions about unique identifiers and how do we identify things across. The reality is we're pretty good at matching with a core set of demographics that are relatively unique to you. They're not unique individually. Male versus female is not unique, right? That's almost 50% of people on the other side, with some other choices relative to, binary decisions, et cetera. We get all that, but that's not unique. That plus my birthday, plus my first name, plus my last name, plus my address, plus my city, plus my state, plus my zip code, pretty darn unique, right? It really defines me as you're really trying to figure out how do I unambiguously determine that this person is the person I'm looking for. One of the problems we had in public health actually is their level of identification is not as high as what we have on the provider side. And I saw it locally, right? There's a strange thing that happens when people don't pay for tests. You don't collect information to make sure you can send them a bill, right? So when I went and got a test, they took my first name, my last name, made sure I lived in the city I was in because they were billing my city, and may have got my phone number. Like often they didn't even get that. So that doesn't work with Exchange with it. So we kind of have to build it and educate and say, look, now we want to plug you in. What we need you to do is, I understand this would take 17 more seconds for every COVID test you did, but you got to get this extra data or it's going to be hard to plug in, and we don't want you disadvantaged going forward. So I think this starts that conversation. And there were some white papers, out of Duke and others that I participated on some of the data collection for that really did find that we were under collecting demographics on the public health side. And we know a lot more on this side than we can educate and share. So let's get them in the tent earlier so they can start setting up their systems to collect the data necessary to truly plug in. Even absent a unique identifier, we can do this.
Mm-hmm.
In addition, from a public health perspective, TEFCA can play a role in making it easier for public health agencies our authorities to get access to the information they need, to the extent that there is a need to have uniformity and there's sort of a collective data set that is could be standardized and uniform across jurisdictions. So what we heard very clearly from vendors, existing networks that serve multiple markets, healthcare organizations that support multiple markets, is that during COVID, they were inundated with requests from hundreds of jurisdictions, each with a slightly different data request. And so there is a tremendous opportunity, again, to the extent that there's need for uniformity across jurisdictions for TEFCA to do that. But I also want to call out that there are a number of local public health or data utilities, often facilitated by HIEs, that offer very rich data for their particular jurisdiction. This would not supplant that, but again, it would be, sort of layering on top to the extent there's need for consistency between or among jurisdictions. That's where TEFCA could play a role.
One of the things that's really a foundational question that goes back from the beginning of electronic health records is, what if somebody says, I don't want my health information exchanged? I don't want it out there. How's that dealt in other countries? How's it dealt with here? Do people have to give permission? Do they give permission when they sign that form first time they see a provider?
So this is where TEFCA points to applicable law. So the data holder is obligated to comply with whatever laws that pertain to them. So if they're required to obtain an individual's consent, but before disclosing information, then they must obtain that person's consent. And so if someone else in a different area requests that information, if they have consent and they can legally disclose it, then they're expected to share the information with the requester. It's a little different with an individual who wants to access their own information. So the service provider or app that they use is required if they want to participate in TEFCA and use that as their entry point to access information for that individual to access their own information, then consent is required. So an individual would have to say, yes, I permit you and I will initiate this request and request my own all my own information and records from these various data sources and bring it back in.
And so that typically is a form that gets signed the first time somebody sees a provider. Most people want their data, clinical data, shared with their insurance company, or else the insurance company won't cover anything. Insurance company ain't going to pay unless they have access to that data. And certainly if you're being referred to a specialist, you want your health information exchanged. And so I guess this kind of falls under that category, that blanket permission. It's certainly not done on a granular basis. I guess it's done on a reimbursement and provider and just clinical. If clinical information is needed in my care, you're given permission for it to be shared. Has that been much of an issue, though? Everybody has been hacked. The government's been hacked. Is there much concern about that, or is the cow already out of the barn in terms of the data is out there already?
Well, I mean, there are probably a couple different issues. Really what TEFCA is saying is, if you're required by law to get an individual's consent to release their information for whatever purpose, then you have to do that, and you comply with the body of law applicable to you, and that's it. That's where it ends. Except with the exception of an individual using an app, that they have to consent to requesting information and bringing it back there. Now, privacy and security is a whole other matter. And this is where TEFCA is pretty strong in terms of permitted uses and disclosures, and having expectations that flow down. There's strong expectations for privacy, looking at HIPAA as a contractual standard of performance, that for those entities not subject to HIPAA, they still have to comply as if they were, subject to it from a privacy perspective, which applies to, again, the apps, which are not generally not covered entities or business associates. It also could apply to healthcare providers that don't conduct administrative transactions and aren't subject to HIPAA. And so there is a subset of the HIPAA privacy provisions that would pertain to them, again, around around uses and disclosures, et cetera. And then the bar for security for QHINs is very high. And that was by design. Again, the expectation is that this could be a pretty attractive target as serving as part of the national backbone and critical infrastructure in the US. And so there was an expectation that QHINs be held to a high bar for security. And then what we are working on is delineating above and beyond HIPAA security for the organizations that connect to a QHIN, what are other expectations potentially around identity proofing, authentication, authorization, et cetera. And that there are more details to work out on that.
Next month in March, there's both the HIMSS conference and the VIVE conference, both of which are in Florida. Are y'all aware of any particular presentation or information that's going to be distributed at those conferences to get people? And really the bigger question is, certainly during this formative year, as we move forward into seeing more and more public action, how can folks keep up to date on what's happening?
The easiest thing to do is to sign up for our listserv at rce.sequoiaproject.org. We do have monthly informational calls. We have 2 intensive Q&A sessions coming up, one on February 22nd that's going to drill down on questions related to the Common Agreement, and then a drill down on Q&A for the QTF on March 1st. For folks that are just getting oriented, those are going to be like master's level questions, like really detailed, assuming you understand the underpinnings of TEFCA. If you're just getting up to speed, we have recorded all of our webinars, educational webinars. I really encourage you all to take a look at those. We will be presenting at VIVE and at HIMSS, and also we'll have an in-person listening session there on Wednesday afternoon at March 16th.
Okay, great. We've only got about 9 more minutes. Let me tell you how I'd like us to spend those next 9 minutes. I'd like each one of you to just kind of spend a minute summing up anything you want to about this, where we are, where we're going, the importance of it. And then if we have some additional time, I know there've been quite a few questions that have come in or things in the chat. I invite you to take a look at those. And if we have time, we can take turns answering 1 or more of those. So let's kind of do that round robin. Leah, I'll start with you. If you could just kind of sum up for us a little bit, sir.
Okay, Jim. So I think what you're hearing, and first of all, I'm very excited. I think the industry is very excited. The fact that on January 18th, TEFCA and the Common Agreement were announced. There's been a lot of people that didn't know whether or not that would happen, when it would happen, et cetera. And so I, for one, and I think many people that I've talked to are very excited about what TEFCA and the Common Agreement will do. A couple of things I think that were mentioned. I think, first of all, I also want to put in a plug for the Sequoia project here in relation to the fact as an RCE, they've spent years, the past several years, working very diligently and very transparently to be as inclusive as possible with the public sector, the industry, et cetera, as they look to develop the Common Agreement and really provide some really great educational tools and resources. As Mariann said, I think they've got some great resources out on that website. So the good news is there's a lot of good information that's available, and there's a timeline here. We've talked about the FIRE roadmap, which is also part of this announcement that went out, which is a 3-year roadmap on how FIRE is going to be implemented throughout this. And again, a lot of this is really to try to make it as easy as possible for patients, EHR vendors, and others to exchange data. FIRE has come a long way. And I think that what we're going to see is, I think that even the FIRE roadmap may be accelerated because I think there's a lot of work that's been going on with fire, and hopefully based upon that acceleration in all the development and the use cases that have gone on with Da Vinci and others, I think we've got a great opportunity to perhaps even accelerate that roadmap and incorporate fire. So I think, the good news is hopefully as we move forward, start to operationalize, start to get QHINs in hopefully the end of this year and in 2023, and people start to see the benefits and the successes out of this. We start to see a lot more entities look to exchange data and submit data into these data aggregation sites with these QHINs. So I'm very optimistic on the plan forward, Jim.
Okay, great. Mr. Paul Wilder, what are your thoughts?
Well, I mean, the major thought is we have a lot of work to do.
Yeah.
So TEFCA dropped, those who are on the inside on that master's level work know that a good portion of TEFCA dropped, but there's still a bunch of other things that need to go along with it. That's why I can't apply today. I can't have CommonWell sign a document saying, let's go. There are a fair amount of standard operating procedures and things that need to be attached. One of the really important ones is how to do individual access services or patient access onto these networks. We really do want to have the provider network working and be able to let patients plug in and get access to the same breadth and depth of data that a provider can, which I think is really important. And we have to get that right. So we're looking forward to that getting advanced. So I think you're going to see a lot of work happening, a lot of conversations. I do think Lee's right. I think we're going to see acceleration of the fire roadmap. Again, we were little naysayers in the beginning, but when you're looking at something new, what can you leapfrog with it? What can you take away that you used to do and advance to something better? And it does align with what vendors have to produce anyway, which is key, right? It's easier to get to the next technology if everybody's already going to the next technology. Now it's just how to do it at scale. So I think this is going to be an exciting year. I'm not sure if we're going to get a QHIN-based exchange going this year between providers, probably very close. And you'll probably start to see a ramp up, really next year when, I imagine, so we have a year to the next HIMSS, a year and a couple of weeks. We'll probably be talking about legitimate exchange going on by then and kind of what to do next. So, it's going to be an exciting year. I'm looking forward to it.
Great. Damon?
Man, I'm just looking forward to figuring out what all these acronyms
I know.
talk about, confusing the heck out of the consumer. Honestly, though, I'm as optimistic as Lee, maybe more, that this could be the beginning of the end of impersonal care experiences in the U.S., which would be pretty awesome. I think it's important for industry participants, both legacy and emerging, to find partners in this venture and find partners that can help accelerate, enable, and in some ways insulate your operations from what I expect is going to be a really rapid set of enhancements and advancements in TEFCA as we go forward. So I'm looking forward to that. It reminds me a little bit of Larry David in that Super Bowl commercial with the wheel going,
Yeah.
right? Like, this is the new thing, and it's going to be cool once we
Exactly.
get things accomplished.
Yeah.
I'm curious if I can ask a super quick question,
Sure.
because Paul, it sounded like your opinion is we're going to have very few QHINs, and Mariann, I'm just curious from your vantage point, do you think we're going to have very, very few, or very many, or somewhere in between? How do you think?
Well, I have a personal projection that I'm not permitted to disclose in terms of who we think. That we say basically there'll be probably 2 or more at a minimum, definitely no more than 100. If we get that to that higher level, I'd be surprised because of the bar that's going to be expected. I think it will be a subset of the networks that we see in the market today. And just because of the expectation that they have the financial, organizational, and governance resources to do this work. And I know we haven't published the specific security requirements for QHINs in terms of security certification, but what the Common Agreement Work Group had advised and what we heard pretty solidly is that high trust would be a good example of one certification, and we're looking at others like that provided by EHNAC. And then as we engage our Chief Information Security Officer, expect that would, we'll have more to follow on that in terms of specific proposals. I think if you, particularly when the eligibility criteria come out in more detail, it's basically hasn't changed too much from the draft we published last year. You could probably go through and start self-selecting.
If it's
Mariann,
100, that's going to be a problem. Let's
Yeah.
try not to have that happen.
Yeah.
Naturally 100. I mean,
So-
a fraction of that, really.
So, Mariann, in terms of TEFCA, you have certainly seen the conception and gestation, and you've seen the baby born. Is the baby crawling yet? Is the baby walking?
The baby has walking shoes.
Okay. Well, that's
But,
optimistic.
we have a viable initial proposal. We're learning as we go. We've already identified probably at least 4 issues we're going to have to tweak, because until you put it in practice, it's unproven. The one thing we have, though, is that we have a decade of track record of doing this and highly successful interoperability initiatives in production that scale and self-sustain. So we just need to get through this initial round of QHIN onboarding and designation, exercise the governance process, refine it. We're super practical. It has an incredible potential to bridge gaps that we have today, but we're going to be very incremental about it, and we're going to be super practical. And that means we need feedback from the community. That's the only way this will be successful.
Absolutely. Well, that brings us absolutely to the top of the hour. That was perfect timing. So I want to thank Lee and Paul and Damon and Mariann for joining us today. And Carol, we're going to send it back to you.
Yeah. I just want to get everybody's contact information up on the screen, and just terrific conversation. I'm glad somebody, Damon, you mentioned my favorite Super Bowl commercial with Larry David. It was brilliant that you.
The best one, wasn't it?
It was the best one. Glad that you worked that in there. It does sort of feel related to healthcare when I watched it, for sure. Thank you all again. I obviously want to thank our attendees. I will work diligently to get a copy of the recording of this out to you within the next 24 hours. And we hope to see you all back again on our next virtual event. Till then, please stay safe and healthy. And again, thank you all to our panelists, and of course to you, Jim Tate.
Great. Thanks so much. I enjoyed it. Thank you, everyone.
Bye.
Thanks,
Thank